Hi, everyone. Thanks for joining. It's a little after 7 o'clock here in Ann Arbor. This is the Mind Matters lecture series, and we'll take a few minutes here before we get started. So thanks for calling in, and we'll start probably at about 2 or 3 minutes after 7. Maybe we can go ahead and begin. Welcome, and thank you for joining the Mind Matters series. Tonight, we're focusing on the topic of the overlap between bipolar disorder and addiction. I'm Mark Gilgen. I'm a clinical psychologist and professor of psychiatry here at the University of Michigan, as well as an investigator at the VA Ann Arbor. And I'm also the director of U of M Addiction Treatment Services here in the Department of Psychiatry. And joining us tonight are experts from the Heinz C. Prechter Bipolar Research Program and the U of M Addiction Center, who are here to help us learn more about the relationship between bipolar disorder and substance use disorders. As a structure for tonight, we will have 3 speakers. They'll each talk for about 10 to 15 minutes, and then we'll have plenty of time at the end for questions. I'll go ahead and introduce our 3 speakers now, and then we'll talk about a few housekeeping items, and then they'll begin their presentations. So our first speaker will be Dr. Sarah Sperry, who is an assistant professor of psychiatry at the University of Michigan and associate director of the Heinz C. Prechter Bipolar Research Program. Her lab, the Emotion and Temporal Dynamics Lab, focuses on understanding emotions and behaviors in bipolar disorder. Using technology like smartphones and wearable devices, she aims to improve early detection and develop personalized treatment. Dr. Sperry's work, with over 45 published articles, is making a real difference in the lives of those with bipolar disorder. Following Dr. Sperry will be Dr. Jonathan Morrow, who is an associate professor of psychiatry here at the University of Michigan. With a background in both medicine and neuroscience, Dr. Morrow investigates how our brains affect behavior and mental health. His research, recognized nationally, explores connections between psychiatric disorders such as addiction and PTSD, and it aims to find new ways to help those who struggle with these conditions. And our third speaker will be Erica Vest, and she serves as a research specialist and clinical social worker at the University of Michigan Department of Psychiatry. She focuses on research coordination and care management, and her responsibilities include conducting clinical diagnostic assessments, coordinating research studies, supervising social work interns, and co-facilitating psychotherapy groups, while also managing research activities like IRB, regulatory affairs, within the Mood Disorders Lab. For a few housekeeping items, the first one's a little unique for us, at least unique for me. I think we're currently under a tornado watch here in Ann Arbor, and hopefully nothing will come of that. But if that changes and things look a little more severe, I'll probably jump in and just let you know, and we'll come up with a plan for how to respond at that time. Hopefully nothing happens. I also want to mention that questions can be submitted using the Q&A button at the bottom of your screen. And there's an option there for you to submit your questions anonymously. Also, you'll notice some messages appearing in the chat. Those are being entered by our team here and will include information about resources, potential links to additional information, and just general facts and information that will hopefully be useful to you. So after the presentations, we'll go ahead and go through questions. We'll do our best to get through as many questions as possible. These presentations are more interesting and dynamic when you're submitting lots of questions. I know we have some that were sent in ahead of time, and please send in any questions that you would like to discuss throughout the presentation. So with that, I want to hand it over to our speakers, Sarah, Jonathan, and Erica. Thank you for joining us. And Sarah, I'll go ahead and let you begin.
Great, thanks, Mark. And thank you, everybody, for attending. Just as a reminder, I am Sarah Sperry, and I am a clinical psychologist. And both my clinical work and much of my research focuses on bipolar disorder and co-occurring substance use disorders. So just recognizing that people are likely coming to this webinar with different sets of knowledge, I'm going to start with a very brief description of what bipolar disorder is for those of you who don't know much about it. So bipolar disorder is a mood disorder in which individuals experience profound mood instability. And that can look like episodes of mania, which are really elevated states. Individuals might experience a lack of a need for sleep and their minds going very quickly. They might engage in impulsive behaviors. And also they might have depressive episodes. So periods where they're feeling low, sad, down, potentially have suicidal thoughts. And then in between those episodes, often individuals are still experiencing some level of mood instability and reactivity that's getting in the way of one's life that they want to live or their goals. So here I have a bunch of fake people, and let's think that they have bipolar disorder or a form of bipolar disorder. I want to show you some prevalence rates of how many of these individuals with bipolar disorder might also experience a substance use disorder over their lifetime. So starting with alcohol, large meta-analyses estimate that anywhere from 40 to 60% of individuals with a bipolar spectrum disorder will have an alcohol use disorder at some point during their lifetime. So this is really nearing half or over half of individuals who are experiencing bipolar disorder. The second most common substance that individuals tend to develop problems with is cannabis. So about 25% of individuals have a co-occurring cannabis use disorder, and we're seeing these rates increase drastically and quickly. The third most popular substance is cocaine, which is a stimulant. And we see anywhere from about 15 to 20% of individuals have a lifetime cocaine use disorder. So taken together, combining alcohol, cannabis, cocaine, and other substances that people may struggle with, things like opiates or hallucinogenics or prescription medications, about 60 to 70% of individuals with bipolar disorder will have some form of substance use disorder over their lifetime. So you can imagine hearing these numbers that the co-occurrence of these two phenomena are really important for us as clinicians and researchers to focus on, understand, develop better interventions for, and really focus on this population rather than exclude them because it's complicated. Now, I know some of you already submitted questions, and this is a question I often get is, okay, well, if so many people have both, what comes first? Do they cause one another? So we know for some people, they have a substance use disorder first and then develop bipolar disorder. That doesn't necessarily mean that the substance use itself caused bipolar disorder, but it could be viewed as a stressor that led to the development of bipolar disorder, amongst other factors. For others, they have bipolar disorder first and then develop a substance use disorder. So there are individual differences as to when these come online and impact people. But what we do know is when both are present, so when they're co-occurring, it's kind of like a vicious cycle. The substance use exacerbates the bipolar disorder likely exacerbates the substance use disorder. So what do we know about some of the reasons why some individuals use substances and develop problems with them? These are common things that my own patients have said to me or research participants have said to me over my training and career is untreated or residual symptoms. So, in general, I'm not having manic episodes or depressive episodes, but I'm having cognitive impairment. I'm having problems sleeping. I'm having emotional reactivity. And, my medications aren't working for those. So I'm going to try something else. And they might go to substances to do that. I would say the most common thing I hear in clinic is to help with sleep. For some individuals with bipolar disorder, substances can help increase energy during a depressive episode and maybe even mimic a manic episode. Others report that they use substances to decrease anxiety, to forget the bad stuff or escape, or just to have fun and feel alive, sensation seek. But despite the very real reasons that people go to substances, uh, using substances at a problematic level and having bipolar disorder is associated with a greater risk of having psychotic symptoms during those mood episodes, having a greater number of hospitalizations, having less time in remission and more rapid cycling, which is when you have lots of episodes repeatedly within a year, higher rates of suicide attempts, greater impulsivity and risky decision-making, and in general, lower quality of life. So what do we know about why this co-occurrence is so high? We don't have one answer, but some of the things that researchers have discovered and emphasized is that both bipolar disorder and addiction involve changes to systems that regulate motivation and reward. So this is at a neural level. So Dr. Morrow does a lot of this research. Individuals with bipolar disorder also may have an increase in susceptibility to rewarding effects of alcohol and substances. So compared to their peers who don't have bipolar disorder, when they use those substances, it feels extra good. And so that perpetuates going back to it. And both bipolar disorder and substance use disorders are associated in general with a greater tendency to engage in impulsivity and make decisions about using substance use without thinking about the consequences. Oops. So just a brief highlight of some of the research we're doing here at the Heinz C Prechter Bipolar Research Program about the co-occurrence of bipolar disorder and substance use disorders. I want to highlight this study that was led by myself and my PhD student, Audrey Stromberg, the longitudinal interplay between alcohol use, mood, and functioning in bipolar spectrum disorders, where we took data from a longitudinal study that we have here in the Prechter program, and every 6 months have measures of people's mood symptoms and their alcohol use and their functioning. And what we looked at was how mood impacts alcohol use, how alcohol use impacts mood, and how those contribute to each other over 10 years. And what we found is that when individuals with bipolar disorder drink more than typical is that for them, that's regardless of whether they have a use disorder or not. Over the next 6 months, they tend to show a worsening of depressive symptoms, a worsening of hypomania or mania symptoms, and in particular, more problems with work functioning. And so when you look at this figure, you can see here on the left that the audit score reflects somebody's alcohol use. When they're drinking more than typical for them, their depression score on the patient health questionnaire goes up. But what's interesting is that on the flip side, when people's depression was getting worse, we didn't necessarily see a large increase in their drinking. So at least over this time scale, it looks like alcohol use over one's typical use is actually predicting a destabilization in mood. Another project led by my lab manager, Julia Smith, we took a similar approach. We looked at how the intensity and frequency of different substances like alcohol, cannabis, and cocaine contribute to suicidal ideation in individuals with bipolar disorder. This is that same data set, and these measures are also taken 6 months apart. And what we found is that when individuals with bipolar disorder use cannabis more than typical for them, over the 6 months, they show more frequent and intense suicidal ideation, but not the other way around. So taken together, we're seeing these very, very real consequences of using alcohol and cannabis and its impact on destabilizing mood and functioning, even if you don't have an alcohol use or cannabis use disorder. This is just use in general. So what can we start to do to think about this? How can we improve? So my clinic argues pretty strongly that for individuals with bipolar disorder and a substance use disorder, they should be engaged in what we call either integrative or parallel intervention, which means you should be targeting both the bipolar disorder symptoms and the substance use systems together with either two teams that are working together, that's parallel intervention, or integrative. You're working with a psychiatrist, psychologist, or social worker who might have expertise in both and can kind of target both at the same time. I think it's really important that for individuals with bipolar disorder, if they feel like their symptoms are unmanaged or they're having residual symptoms that are getting in the way of their life, to talk to your providers about that before trying non-prescribed substances to help. And our research in the Prechter program is really highlighting that it's important to focus on reducing use and avoiding sudden increases in use. Again, those sudden increases in alcohol or cannabis use were contributing to mood destabilization. So with that, I will say thank you and pass it on to our next speaker, Dr. Jonathan Morrow.
Okay, great. So let me share my screen here. There we go. Okay. So I'm going to add a little bit to what Dr. Sperry was saying from my perspective as an addiction psychiatrist. Um, and one of the points I'll make here that Dr. Sperry kind of touched on is that the mood symptoms with bipolar disorder and really other psychiatric disorders worsen outcomes for the substance use, as well as, the substance use worsens outcomes for mood disorders, where the reverse is also true. The mood symptoms worsen substance outcomes. That's in terms of relapse rates, treatment response, and even things like physical health, social interactions. These kind of things are all worse among people who have the two diagnoses at once. And what I think is interesting that's come out of the research on this, um, this is this is mostly research on unipolar depression, so people who have the lows without the highs necessarily. But what's interesting about that is even subclinical depression, meaning depression that is fairly mild and not so severe that we would actually treat it in most cases, even subclinical depression will worsen outcomes for substance use. And people with a major depressive disorder that's in remission, meaning that they don't have mood symptoms right now, if they don't have mood symptoms, their outcomes are not different from people who don't have major depressive disorder. So that tells me that it's important to treat these mood symptoms because that's going to have an impact on the substance use. So if you can actually get the mood symptoms under control, then that can really improve outcomes in terms of substance use. And diagnostically, it can be challenging to identify bipolar disorder in the setting of substance use, and sometimes vice versa. One of the challenges that we see is that patients often lack insight into these disorders with both bipolar disorder and with substance use disorders. There's what we call a pathological lack of insight, where the patient cannot see uh, that they have a disorder. Um, they can't see the dysfunction in their life that's so obvious to other people. Um, so if as a clinician, as a psychiatrist, I don't have a test that can tell me definitively this person has bipolar disorder, or even that they have an addictive disorder. I can detect whether they have drugs in their system right now, but I can't really tell if they have a substance use disorder. So a lot of what I'm relying on is the patient's history that they give me, the story that they tell me, in addition to what I'm seeing in the office, just talking with them. And if they don't see it, if they don't see that they have these symptoms, it can be really hard for me to determine, the reality of what their mood symptoms have been like, what their substance use is like. So that's a real challenge. And it requires that the physician do some comprehensive screening with every patient that comes in the door, because they may not be complaining about this disorder. Maybe because they don't think they have it, maybe because something else is more pressing on them. But I would need to really delve into it with every patient, no matter what their complaint is, in order to pick up some of these disorders sometimes. Um, Another complication is that you can get psychiatric symptoms from substance use. So intoxication or withdrawal from substances will cause mood symptoms that can look very much like bipolar symptoms. An example of that is stimulant use. If someone is intoxicated with a stimulant, whether it's amphetamine, methamphetamine, cocaine, that looks basically identical to a manic episode, a bipolar manic episode. I don't have a way to distinguish that clinically. And then withdrawal from stimulants, when you stop using, that causes depression, which again can look like a very profound depressive phase. And so if someone is repeatedly using stimulants, binging and then stopping, and then binging and then stopping, that can look like a bipolar mood pattern. And so if you don't put that together with the substance use, you could be fooled into thinking that someone actually has a bipolar disorder. Uh, However, that said, it's not uncommon at all for people with bipolar disorder to use substances during their manic phase, preferentially or even exclusively during their manic phase. Sometimes that's done in the case of stimulants in order to enhance those psychiatric symptoms, because the mania or the hypomania feels good to the patient, so they may want to extend that feeling or enhance that feeling with stimulant use. And so you can get a history that the person is only using substances, or they're only having these mood symptoms when they're using substances, but that doesn't mean that they don't have a bipolar disorder necessarily. Um, you could also get especially during the manic phases, these impaired judgment, increased impulsivity, a lack of awareness of the consequences of drug use that can lead to more drug use during these manic phases. Now, if that happens repeatedly, you are using an addictive substance, and so that can lead to a substance use disorder, because it doesn't really matter why you were using the substance in the first place. If you are exposed to it repeated like that, it's very likely or very possible that you could develop a separate substance use disorder on top of the mood disorder. So things that can help diagnostically would be a good timeline of these symptoms. Which came first? Was it the drug use followed by the mood, or the other way around? An extended period of abstinence for at least a month or two, preferably more like a year of abstinence from substances. If we're having mood symptoms during that time, that can be very helpful diagnostically. And family history can also be suggestive, because both bipolar disorder and substance use disorders have a strong genetic component. I think with bipolar, it's pretty strong. It's like 60-70%, if I remember right. Whereas with substance use, it's more like 50%, which is less strong, but still pretty strong. So if you have a strong family history, lots of family members with bipolar disorder or with substance use, that might raise the suspicion, as opposed to nothing like that in the family at all. That might lower the suspicion a bit, but it can be complicated to determine which is which here. But I think we're supposed to focus more on treatment, so we'll talk about the treatment models. Again, Dr. Sperry touched on this a bit, but there's three models for kind of broad models for treating a comorbid substance use disorder and psychiatric disorder, including bipolar disorder. One is sequential treatment, and the approach here is to stabilize whichever condition is more acute first, and then address the other problems. So, for example, if someone is having an acute mood episode or acute mood instability because of their bipolar disorder, get that under control first, and then address the substance use. Or vice versa, let's get the substance use under control first, and then we'll address the mood. The problem with that approach is that it doesn't address how much these two disorders are interrelated with one another. And in many cases, basically all cases, to some degree, the mood instability is driven by the substance use, and vice versa. The substance use is driven by the mood instability. So you can't really effectively address both of those, or one of those, without addressing the other. It's kind of a fool's errand to try to stabilize someone's mood when they're actively using substances, or to have somebody stop using substances when their mood is totally out of control. So you really, it's very clear from the literature that treating both at the same time is the optimal approach. And so ideally that would be done through integrated treatment, which means the same treatment team is addressing both disorders. You clearly get the best outcomes with that approach. The challenge there is that it requires staff with an extraordinary level of training to do that. They need to be experts in treating both addiction and bipolar disorder, and there's just not a lot of systems that have that level of expertise. A lot of addiction centers, they're very good at treating addiction, but they may not have expertise at treating psychiatric disorders, including bipolar. So if that's not available, the integrated treatment, the next best thing would be parallel treatment, where you're having two sets of providers, one treating the substance use, another treating the mood disorder. The key to making that work, though, is close communication between those teams. That way you don't get people working at cross purposes, using contradictory approaches, contradictory treatment philosophies, with the patient caught in the middle saying, well, this guy's telling me this other doctor is telling me that. Ideally, they're talking to each other so that everyone's on the same page. So there are integrated treatment options for bipolar disorder. There's an integrated group therapy that's been developed for treating both bipolar disorder and substance use in the same therapy modality. There's assertive community treatment, which that's usually done by community mental health through the county. And especially if someone has a severe persistent psychiatric disorder, that's usually the best treatment to get is through those county services. So that can be very effective. There's motivational interviewing techniques that have been developed for people with both addiction disorder and another psychiatric disorder. Family interventions can be very helpful. There's something called contingency management that works very well for substance use. But in this population with people with comorbid psychiatric disorders, it's not the effect on outcomes has been pretty mixed in the literature. It certainly improves attendance, but and then 12-step facilitation, which is aimed at increasing participation and peer support, things like Alcoholics Anonymous. That's generally not been very impressive in this particular population. However, peer support itself can be very helpful. And there's several self-help groups that seem to improve outcomes for patients with multiple disorders, including bipolar disorder. Alcoholics Anonymous historically has been kind of hostile towards psychiatric medications in general, but there is official AA literature that endorses the use of psychiatric medications, and I think that attitude is largely gone by, not entirely, but it's largely gone by the wayside in the AA community. And there are some specifically dual diagnosis peer support groups. I have some of them listed here: Double Trouble in Recovery, Dual Recovery Anonymous, Dual Disorders Anonymous, that are designed to, or they try to specifically help people with multiple psychiatric disorders. In terms of medications, there haven't been a lot of well-controlled studies on people with both bipolar and substance use disorders. A lot of times people will specifically exclude people with substance use disorders if they're studying bipolar, which is understandable, but it really leaves out the majority of people who actually have these disorders. But it's pretty clear that standard mood stabilizers, certainly lithium, valproic acid, some like the standard ones that people use for bipolar disorder, are effective in people who also have a substance use disorder. So that approach should not really be that different. We have a few medications that we use to treat substance use disorders. And for bipolar patients, generally they seem to work about the same, or they're efficacious. And there's some slight differences. So in the case of alcohol, there's disulfiram, which makes people sick when they use alcohol. Disulfiram generally is not a preferred treatment for alcohol use disorder, but particularly with bipolar patients, it can increase psychosis. So we tend to stay away from that one. It also doesn't treat cravings, which is really the heart of addiction. But it just makes people sick if they use, but it doesn't reduce their cravings for alcohol. There's naltrexone and acamprosate, both of which will reduce cravings. They're both effective, and they seem to work with bipolar patients as well. For opioids, we have buprenorphine and methadone, both of which are highly effective treatments. We don't have a lot of data specifically in bipolar patients, but we don't have really any reason to believe that it wouldn't work in bipolar patients. And I've used it in my clinic quite a bit for bipolar patients. Naltrexone, which blocks opioids, is another viable option, but it can induce mania in bipolar patients, so you have to be a little cautious with that. I do want to mention nicotine as well. Oftentimes this gets overlooked, but most addiction patients actually die of nicotine-related illness. They tend to put that off as I have bigger things to deal with than smoking, but that's actually what people are going to die of. So it's important to address that. And there are medications that can help with nicotine. Certainly nicotine replacement with a patch or a gum is useful. Antidepressants are also, so there's a couple of antidepressants that are useful. Just have to be careful about antidepressants. You have to give those with a mood stabilizer if you're treating bipolar patients because they can induce mania without a mood stabilizer on board. And then there's varenicline, which has been there's been concerns with varenicline because a lot of people would take that and get an exacerbation of psychiatric symptoms, increased suicidal thoughts, among other things. But it's very clear now from other studies that varenicline is safe to use in people with mood disorders. The increase in suicidality and mood problems is actually from the nicotine withdrawal when you stop nicotine. The varenicline doesn't have any effect on that at all. It gives people vivid dreams, but that's really the only psychiatric symptom that it's been shown to have. So that's safe and effective treatment for nicotine as well. All right, so we need to. I'll just summarize some key points before we move to the next speaker. So number one, diagnosis can be tricky with bipolar and substance use disorders. But it's very important to treat both the mood symptoms and the substance use simultaneously because they're so interrelated with each other. So integrated treatment is the optimal approach if you can get it for these two disorders. And there are treatments that are available for both bipolar disorder and substance use disorders. They're safe and they're effective. And so if you have both of these disorders, you really should get that treatment. All right, so with that, I will stop sharing and hand it over to Erica Best.
I will share my screen. And someone can let me know if there are any issues with seeing what I'm presenting. So hello, everyone. I just want to thank you all for taking the time out of your evening to be with us tonight and attend tonight's webinar. My name is Erica Beth Wilcox, and I'm a licensed clinical social worker, and I work with the Heinz C Prechter Bipolar Research Team. And on the team, one of my main responsibilities is conducting the clinical assessments at baseline and follow-up. And so I'll tell you a little bit more about that before I get into my presentation. So what I'll be speaking to you all about is bipolar and substance use in our longitudinal study cohort. But again, before going into that, I'll tell you a little bit about our longitudinal study. So our longitudinal study has been going on for many, many years now. I think we're approaching close to 18 years. Originally, we intended to have participants come in and we follow them for the course of 10 years, but that has extended beyond that period of time. And we're continuing to go, and our participants seem to really love engaging with us, and they have stayed with us for a very long time. And so we've got a number of data points from that research that we've collected so far. So in the longitudinal study, we recruit participants with a bipolar diagnosis and also those without a diagnosis. And again, we follow them over the course of time. So at baseline, we will do things such as a structured clinical diagnostic interview, which is where I come in. And I am just gathering a history of these individuals' background, demographics, kind of getting a social history, as well as just learning about them, their medical history. And then we take a deep dive into their their mental health and also substance use. So we'll ask them several questions to see if they meet criteria. And then every 2 years after that, we follow up with them and we conduct a longitudinal follow-up interview. And at that point, again, we collect similar data where we will see if there have been any significant life events that have occurred from them. And that is really important information to collect as, you know, if something in their life changed, that can exacerbate their mental health as well as their substance use. So that we want to gain that information. We also gather information about their medical history because we know that that can interfere with mental health. And then again, we see if they continue to meet for a mood episode or if their mental health has stabilized. And then we also see if they continue to meet for a substance use disorder or if one new has emerged. So that's what I'll be talking to you about today is some of our findings and also some interesting points from some of the interviews that I've conducted that I just want to mention today. So to start, use of substances vary at baseline and follow-up. So for example, there are some participants that we meet at baseline and they have no prior substance use history, and we'll gather that at the baseline diagnostic interview. However, maybe several years after follow-up, just to give an example, there may be a participant who had a very stressful life events that have gone on. So their mood had continued to fluctuate. They may have lost a job, or something serious happened, and then they began using a substance. And then at that point, we see that they developed a substance use disorder. And then maybe 2 years from there, we see that that has subsided, and it may continue for the duration of the study that they don't have any other issues. So it really looks different. And then again, there are others at baseline where we see that they start with an initial diagnosis, not an entry, but just a history of a substance use diagnosis. But throughout follow-up, they have said they have not met criteria for any condition since then. So these are just a few statistics, and I'm just going to put these both up at the same time. And I am not a statistician. I'm also not a part of the data team, but these are some of the statistics that I collected. So if you have specific questions that you would like me to gather, I can certainly do that and bring it back to them and follow up with you all if you have additional questions. So I do just want to mention one of the things that we see is at entry of our study, individuals really meet for alcohol and marijuana use disorders. And that's where we see a level of dependence. So you'll see 25 or 29% for alcohol and 18% for marijuana. And then we also see cocaine use at 7%, opiates at 5%, and sedatives and stimulants at 4%. So they're still present, but the ones that really stick out are alcohol and marijuana use. And we really have seen an increase in marijuana use, especially over the last few years with the legalization of it, as well as people who have used it for medical reasons. So there's been an increase there. And I can say from an interviewer standpoint, especially when I'm doing the baseline diagnostic interview, those are modules we tend to take a deep dive in for alcohol and marijuana use. And even if someone does not meet the criteria, we usually have to go through those just to assess for that. And then 55, what was also interesting is that, throughout the interview, at some point during follow-up, 55% report no substance use of choice. So it seems to be that over time, this is kind of starting to decrease and they are no longer choosing to use substances. However, I definitely want to mention that this number is not a set in stone number and 100% accurate because, again, it does fluctuate and it varies from person to person. But over time, it does seem that people kind of taper off when they're using and just decide to no longer use substances. And from some of the reports that I've heard from individuals, they say, like, especially as they've been with bipolar for a long time, they start to say that they notice their patterns, they notice their triggers, they notice the things that happen to them when they do use substances, so they decide to just discontinue use altogether. So another interesting point is early use of alcohol. Let me just check something quickly. Okay. The other thing that I noticed is early use of alcohol. So there are some of our participants that report really early use, as early as preteen, sometimes during teen and adolescence. And the point that I want to make there is a lot of these individuals are starting to report symptoms early on. And because they're so young, they don't really know how to cope. And so they may have access to things like alcohol, may use their parents or things that are around them as a way to try and cope, not realizing that that may actually be worsening their symptoms. And so at that point, a lot of times their parents may be able to pick up on some of their mood symptoms, but they don't necessarily know that they're engaging in any other substance use. So the parents may take them to see a provider, and the provider can kind of start to treat them for whatever symptoms that they're presenting with but the substance use is not known or disclosed until a later period of time. And then there's also things that I've noticed when I've done the interviews is increased mood episodes and use of substances in college. So again, one of the things that we know is despite a bipolar diagnosis, many people, when they enter college, they begin to use and experiment with drugs and other substances, alcohol. But for individuals with bipolar disorder, this can be particularly detrimental. They report soon after starting to experiment with these drugs and or alcohol and using them that their mood may worsen, that their episodes may become longer. And then it can become to the point where it gets extremely severe to where they start to experience suicidal ideation. We've seen reports of hospitalizations as well as first manic or hypomanic episode that may come up. And then another challenge is when these individuals start to use or experiment in college is that they may notice issues or changes in their life and functioning. So when we talk about people in college, for example, there are times when they may have to take a leave of absence, they may have to withdraw, they may no longer be able to perform, so their grades may decrease. And in some extreme situations, we see that people have to drop out altogether, and sometimes they no longer are able to return. And other impacts that this can have on their life is, in addition to school, some people find that when they have this co-occurrence, they're no longer able to work. They have difficulty maintaining their home lives. And they also may struggle in their relationships, particularly with people if they don't understand exactly what is going on in their loved one's life. So those are things that we tend to see. So that was an extra thing, so I'm sorry about that. But the other point that I definitely wanted to make is that underreporting and stigmatization is something that has come up significantly. So the beauty that I feel comes from the longitudinal study is that we are able to follow these individuals over the course of time. So at baseline, a lot of times people, there are some cases where people are new to the bipolar diagnosis and they're really not sure what's going on. They are learning about bipolar and they really don't want to be labeled. And so to add another label of substance use, they just refrain from it altogether. And sometimes we see that they just don't tell us at baseline about any substance abuse or use. But again, with us following them longitudinally, they start to become comfortable with us again over time, and they start to feel like they can express things that have been going on in their life or the use that they may have had. And so again, whereas at point 1 or point 0, they may not have disclosed that information, by year 4 or 5 or 6, they're starting to become more comfortable and tell us that, and that's where we're picking up on the diagnosis. So underreporting definitely happens, as well as stigmatization in general, which is why people fear coming out and talking about these things. And I think for us, like, some of the things that are very important are going to be helping to reduce that stigma and helping people become more educated, including people's loved ones, people in the community, as well as providers. I mean, us as providers, although we are considered experts, for example, on this platform, we don't know everything. So it is very important for us to continue to educate ourselves to reduce the stigma and also educate others. I think something that Dr. Morrow talked about was certain programs or therapies that are tailored towards this. So making them known so that people have the resources. And even with AA and things like NA, making those things available to people, whether they're 100% beneficial or not. I think people find support and camaraderie in those things. And sometimes they find lifelong friendships with people who they feel can relate and who provide that level of support. And also, I just think there are also support groups for family members. So I know that there were some questions about like family and how families should take care of individuals who are struggling with this. It's important for family members to integrate themselves within the care as much as the person feels comfortable, but also to get care of themselves. So take care of themselves, attend support groups so that they can educate themselves and just, again, be there for their loved one. So with that, that is all I have for our findings. I could talk about it all day. But if you have any other specific questions for me, I think we're going to head into the Q&A. Feel free to let me know. And again, if I don't know the answer, I can ask one of my colleagues. So thank you all.
Wonderful. Thank you, Erica. And we'll give Jonathan and Sarah a chance to turn on their cameras. Thank you all for the terrific presentations, and thank you, those of you in attendance, for sending in so many good questions. I've seen them really coming in fast and furious here in the Q&A, and please keep that up. You can still send them in. So maybe we could just start by talking about that process of addressing co-occurring bipolar disorder and substance use. All of you touched on this, but how do you begin that conversation? How do you start where someone is really feeling like substances are a big part of how they manage their bipolar disorder or manage their ups and downs? And here you're thinking that maybe changing their substance use may be key to actually helping with their bipolar disorder. How do you navigate that? Can you talk about that a little bit?
I'm happy to start. So that's definitely a difficult place to be in, both as an individual experiencing bipolar disorder and substance use, and as for family members, caregivers, and support givers. And, when I'm working with patients and families, the thing that I always try to focus on is helping the patient themselves identify essentially the pros and cons of what they're doing right now. And at times I try to make that agnostic to substance use, right? Because if I come right out and I say, like, tell me about the pros and cons of your alcohol use, right? That can sometimes get people defensive. So I try to take the perspective of what's working well for you right now, what's not working well for you. Let's think about that. So, you're telling me that X, Y, and Z is going wrong. You're not able to do this. Well, let's think about some of those things that are going well and not going well and how those might be contributing. And really just have a conversation with either family members or patients about, how can I motivate you to recognize a need to alter your behaviors? And that process takes time and might not happen overnight, but through those conversations, I like to lead patients themselves to a place where they recognize it might be worth at least experimenting, trying to change my substance use and see if it helps. So taking kind of this curiosity. So that's the approach that I often take in my own clinical work, especially if somebody at first is like, well, this is the only thing that's helping. Like, I get this a lot with people using cannabis to sleep or reduce anxiety. But actually, when you get down into the weeds with them, well, tell me what's good about it. Tell me what you notice is bad about it. Often you hear people talking about the profound kind of hangover anxiety and low mood that they get the next day, even if it helps them sleep. So you can use that information to try to help promote a willingness to change.
Yes, and I would also like to piggyback off that because that's an excellent point. I think some of the things when I've done clinical work at the initial stages, I'm just getting background information. I'm just really trying to let them vent and tell me where they are. So I'm trying to meet them where they are and kind of get an understanding of why they feel they need to use these substances. And then once I get an understanding of that, then we kind of assess their readiness to change. And like Sarah mentioned, is extremely important is doing the pros and cons, but also figuring out the why they're using it. So for example, like when Sarah mentioned, if it's for sleep, well, then maybe as a therapist or someone that's helping with their care, we can think about other mechanisms to help them sleep to avoid using alcohol. So we try to use some of those strategies.
And I would say I think you both got a little ahead of where I was with this because I would say as a patient, I would just talk to your provider about it. Like step one is just talk to your medical provider. That could be your primary care doctor. They often have screening tools that they can go through with you and try to identify an issue if it's there. They have referrals that they could do and give resources to give you. You can also seek out specialty care yourself. We do those types of screenings quite often in UMass, where I am, the U of M Addiction Treatment Services. So we're happy to have that kind of conversation with you and just see what kind of things would be whether we think there's an issue, if there's more that we need to do to explore that, or if there's some kind of treatment that would be useful for you. We're happy to do that. Yeah.
And along a similar line, what about for families? How can they support someone if they're concerned about this either worsening mood or worsening substance use or both?
So one, I think if the patient is willing to allow their loved one to be involved in their treatment, that could be very beneficial, especially as they start to figure out their patterns, their triggers, and what their medication or treatment regimen is. The more of a loved one can be involved in that, the better then they can intervene. So I think that that's one of the things. The other thing that I mentioned is like attending specific groups. If there are some support groups that a family can attend, then do that together. I also think family members educating themselves. So there's lots of psychoeducation on things like the co-occurrence of bipolar disorder and substance use. I think if they know of those things, the materials are widely available on things like Google, but even like sometimes the provider can give those things to them. So the more that they are knowing about these things, the more that they can help their loved ones. And then the other thing that I mentioned earlier in my presentation was like taking care of themselves. So they may need to get their own individualized treatment in order to deal with and cope with it. And so then their provider or their therapist can provide them with treatment strategies or different strategies that they can use to help their loved one.
Yeah, and there are a number of interventions specifically for friends and family who have loved ones dealing with substance use. So you can go to a specialty provider for addiction services and they can do an evaluation of someone who just has a loved one who has substance use. That's totally fine as well. And there's peer support groups like Al-Anon and things that can be useful as well. So there are resources for that specific issue as well.
I'll mention for bipolar disorder, there's a whole evidence-based treatment called family-focused therapy for bipolar disorder. And one of the things that this treatment does really well is help family members navigate what it looks like to, look out for early warning signs for mood stabilization, but also how to handle that in a way where parents aren't becoming helicopter parents or actually exacerbating symptoms by constantly asking, did you use alcohol today? Did you use alcohol today? Or, did you smoke? Are you high? Because that type of communication isn't always in the best interest of the family member. So looking for family-focused therapy for bipolar disorder can be really helpful. I would also orient family members to both NAMI, the National Alliance on Mental Illness, which has many different groups for peer support and friends and family, and the Depression and Bipolar Support Alliance, DBSA, which also has a lot of resources and support for family members of individuals with bipolar disorder. We also, on our Prechter website, which I know has been shared with you in the chat, we have a learning community of individuals with bipolar disorder or family members, and then also some of us on the team, Erica and I, are also on this committee, and we came up with a long list of resources across different areas that individuals with bipolar disorder might struggle with. So that's available on our website for you to take a look at more locally if you're interested in some resources.
Great. We had a handful of questions about specific substances, and two in particular, or two classes I think are worth talking about. One is cannabis. You alluded to this a little bit, Sarah, but I'm curious to know what you think about cannabis use in bipolar. We certainly hear about medical cannabis. A lot of people talk about it being beneficial and now legal to use. And I'm curious to hear what you guys think clinically about that.
Sure. So I always start my answer to this question by saying, I want people to be doing well. I want people to be able to cope and, live the lives that they want to live. If you feel like cannabis is playing a big role in your stability, then I am not, necessarily going to get in the way of that. But what I do know from the research perspective is that cannabis has detrimental effects on bipolar disorder. There is no study I am aware of that suggests that medical cannabis is a treatment for bipolar disorder. I showed some research with you that we see a relationship between increased cannabis use and suicidal ideation in bipolar disorder. And I also did some research where I got my addiction training at the Medical University of South Carolina that showed that while cannabis helps in the short term for sleep for individuals with bipolar disorder, in the long term, it actually contributes to more fragmented sleep and circadian rhythms. So it's got this short-term benefit of it's sedating, I'm falling asleep faster, it's calming me down, but actually over time, it's disrupting the body's ability to entrain its 24-hour rhythm, which is something that's very critical in bipolar disorder. Changes in sleep can actually cause mood episodes. So from my clinical and research perspective, I'm very honest with my clients. There is not evidence that cannabis is a viable treatment for bipolar disorder. And if you find that it is helping with X, I will hear that. I will listen. We will talk through that. And I will also help you think about whether there might be other things that we can try, or see whether you'd be willing to try other things, knowing that research evidence.
And I'll also add that there's a lot of times people see benefit from cannabis, other substances as well. They'll see benefit from that because they're actually physiologically dependent on it, which develops really rapidly with cannabis. And so if you stop using cannabis, you feel worse because you're in cannabis withdrawal. And so then you use cannabis and then you get better. All these, the anxiety goes down, you're sleeping better. But really what you're treating is cannabis withdrawal, which can last for 3-4 months easily in the case of cannabis. So it can be that can fool people sometimes into thinking that this substance is actually helping when really it's causing the problem in the first place. So.
What about psychedelics? So there's a lot of interest right now in psychedelics, and I'm curious to know what you think about the psychedelics, mushrooms, those types of treatments, and those types of substances, potential treatments for bipolar disorder. Is there research out there?
So I don't know if Sarah's aware. I'm not aware of studies on bipolar disorder in particular. There are with depression, but so do you
Right.
know?
There are two trials that I'm aware of currently in bipolar 2 disorder. So for those who don't know what that is, individuals with bipolar 2 disorder experience repeated major depressive episodes, but have a kind of milder form of mania that we call hypomania. So this is still a very impairing condition and has typically a lot more depression than bipolar 1. There are two trials looking at psychedelic assisted psychotherapy. Both are in the very early stages. So I cannot comment on their efficacy. Um, there is one trial that I'm aware of that started in non-bipolar, and they did see some psychedelic induced mania, and so that trial was shut down. So votes out, not sure. And it seems like there's some risk for certain individuals with bipolar disorder where we would not want to pursue that as a treatment.
Great, thanks. For the next question, can you talk a little bit more about alcohol? So we were talking some about drugs, but with alcohol, is there a level that feels safe and appropriate as a way to manage symptoms, or is it always problematic? To what extent do you worry about drinking in for someone who is struggling with bipolar disorder? When do you think it starts to feel problematic?
So I would say that it varies based on individuals. So for any substance, especially like alcohol or marijuana, you don't you I would recommend like using alcohol in moderation, but I would if I could, I would steer clear of it. But some individuals feel that they can function with small amounts. Once it starts to become problematic, we start to see that they tend to meet criteria for like alcohol abuse or alcohol dependence, and then it starts to interfere with their lives. And so some individuals just have chosen to say, you know what, I'm not going to use any alcohol at all. Whereas some people say, like, I can use just a small amount, maybe a glass a week or a glass a month. It really varies based on the individual and what they feel that they can tolerate. But it's best. I mean, as a clinician, I would recommend if you could steer clear from it, I would do so because it does seem to have such an impact on symptoms and can worsen or exacerbate them.
And I'll add a couple points here. So, one is I'll orient you back to the point I made that individuals with bipolar disorder essentially have a brain that is primed and ripe to develop a substance use disorder. There is, dysregulation in the reward and motivation systems that just make it much more likely that you are somebody who won't continuously be able to use it in moderation. You're at much greater risk for developing dependency on it than individuals in the general population. In addition, that study that I highlighted, individuals who even had alcohol use that was below the harmful and hazardous threshold on that measure, if they went from 0 to that, they were showing mood instability. So that data seems to suggest it's any level of alcohol if it's an increase from that person's typical use. That being said, I agree with Erica that I have seen several of my patients, use alcohol in moderation and not seen significant consequences from it. And for those individuals, I emphasize a couple of things. One, avoid binge drinking as much as you can. 2, try to drink as early in the day as you can if you are going to drink. So again, knowing that sleep and circadian rhythms are so core to bipolar disorder, we know that alcohol impacts sleep staging. And so if you're drinking a lot right before bed, you're likely going to have worse sleep. You might not get as much deep sleep. Your sleep might be more fragmented, and that puts you at risk for mood instability. So it's about harm reduction. It's about thinking about, I want to use it as little as possible. I want to use it in contained situations that aren't risky. And I want to use it not a lot right before bed, which I understand socially is difficult. But we talk through those things, and that is my recommendation for people who do want to use it. But it's a risky decision either way, I would say.
And I just want to highlight that it's we're talking about mitigating risk with alcohol. It's not good for you. like in any amount. It's kind of like what's the optimal amount of alcohol? It's kind of like what's the optimal amount of Twinkies? Actually, none. It's not good for you. So it's about mitigating risk with that.
And you all talk about prognosis. So we've talked here about reasons to be concerned and things we might worry about for people who are struggling with their mood and substance use. But how do people do long term? How concerned should someone be? How optimistic should they be? How do you look at someone's longer term trajectory when they're struggling with both of these conditions?
So yeah, we have a tendency to talk a lot about the risks and all the things that can go wrong. That's our clinician hats on. I do want to highlight that many individuals with bipolar disorder thrive. And I answered this in the Q&A. You know, many have fulfilling careers, have families, live the life that they saw themselves living. So by no means is a bipolar disorder diagnosis a death sentence or mean that you're going to be on disability. You know, some individuals really struggle and do need a lot more support and aren't able to work. But most of the individuals in our longitudinal study are, you know, not ending up in the hospital. They, you know, are having prolonged periods of stability. They are getting married. They're having children if that's a goal of theirs. They are, you know, having experiences. We can work with them to even plan their travel so they don't have a, you know, a shift and become manic when they go over to Europe. You know, there's a lot of ways that you can live a very fulfilling life. And I think the key to that is, you know, one, a combination of medication and psychotherapy. 2, living a healthy lifestyle. And by that, I mean really prioritizing your sleep and reducing kind of variability in your day-to-day situations, not, you know, having these big changes in your lifestyle as much as possible, seeking out additional support when stressors are present. And, you know, I think, like Erica said, we do see that in general substance use decreases as individuals with bipolar disorder age. There are many that still struggle throughout the entirety of their lifetime with both. But for people who are able to reduce harm related to their substance use, those who are able to abstain from substance use altogether, you know, can have a very good prognosis. So there is a lot of hope. And, you know, I think if you are one of those individuals struggling, coming to this even webinar is a first step in just learning this information. So if you're concerned about these types of things, if you have a family member who's concerned about these things, like Dr. Morrow said, just talk to your provider about it. Open the lines of communication and start that conversation. The sooner you have that conversation, the better your prognosis is.
and it's, very similar things for addiction. It's similar in a lot of ways to bipolar disorder. It's a chronic relapsing disorder, and there are treatments that work for it. And so, there's varying levels of severity, and but people can do very well with this. They're going to do a lot better if they get treatment that's effective for it, and stick to that. But yeah, it's a manageable situation.
And we have a question here that's specific to bipolar disorder, but there's probably parallels with addiction too. That is, how do you know the difference between someone who has a bipolar disorder versus someone who's just moody? What can you talk a little bit more about the ups and downs of bipolar disorder and how those differ from the ups and downs of life in general?
Great question. Happy to take that on. So this is an important clarifier because I think colloquially, as people go out in their normal daily lives, we hear people talk about the weather being bipolar. We hear people throwing out, oh, you're being so bipolar because they're, saying one thing and then acting another way. While individuals with bipolar disorder have more day-to-day moodiness, that is not necessarily their bipolar disorder. Like, that's not the core diagnostic feature of their bipolar disorder. Individuals with bipolar disorder have prolonged periods of moodiness, meaning they might have a mood change that lasts and by definition has to last at least a week unless they end up in the hospital or somewhere like jail. This is a prolonged period of changes in mood and behavior and cognition. It's not just feeling bad or feeling happy. Depression, you might feel slowed down. You might have insomnia or hypersomnia. You might withdraw from things that give you pleasure or not experience pleasure at all. In mania or hypomania, you might be talking 1,000,000 miles a minute. Your thoughts might be going through your head 1,000,000 miles per minute. You might have new creative ideas and, quit your job on a whim to go explore those. This is not just, oh, I'm happy from 9 a.m. to 11 a.m. and then all of a sudden I'm, not the most fun person to be around. These are really profound episodes. That being said, the caveat, and I focus on this only because there's a perception that it's just those episodes, right? And outside of those episodes, I'm totally normal and normal. None of us are normal, but euphonic, which means not having a mood episode. That there isn't mood instability. And that's not the case. There is mood instability. Individuals with bipolar disorder, even when they're not in an episode, are more reactive to stress. They're more likely to feel emotions with higher levels of intensity. So it can look like moodiness, but it's moodiness on top of also having those episodes.
That's really helpful. In looking at some of the questions, several of them have to do with families and resources for families. I just want to reiterate what several of our speakers have mentioned, and that is that most of our programs here at U of M have services for families. We see as part of our jobs to help connect families with resources, both in terms of professional resources as well as other organizations in the community like NAMI and also substance-related services that can be helpful. So if you are a family member of someone who suffers from bipolar disorder and or substance use disorders, please speak up and advocate for yourself, ask for help, ask for suggestions, and most providers are willing and eager to have that conversation and to try to help out. Um, One question, since we talked about sleep, I'm curious what you guys think about this. What sleep aids can be used? And I guess balancing the potential benefits with the abuse potential. What about the question asked specifically about Benadryl, but are there other things, either over the counter or other medications that are effective to help?
So I can speak as a clinical psychologist, and maybe Dr. Morrow can speak a little bit more from the medication standpoint, but um, so there are very effective psychotherapies for sleep problems. Cognitive behavioral therapy for insomnia. It's actually my favorite treatment to administer. There is no other treatment that I deliver where it just works so well. If people are adherent to it, it can take 6 weeks and be life-changing. So I always, for my clients, want them to go through a really structured, strong cognitive behavioral therapy for insomnia protocol before I'm calling their psychiatrist and saying, hey, let's think about other possible medications. There are also other sleep and circadian treatments that are coming online. And we have a grant right now here at the University of Michigan, a collaboration between myself and the Sleep and Circadian Research Lab, looking at trying to stabilize and kind of shift the circadian rhythm of individuals with bipolar depression. So there's with things as benign as low doses of melatonin, but timed really specifically, not just right before bed. So there's lots of interesting non-medication interventions that can be very effective for improving sleep. Um, and then a lot of the psychiatric medications that individuals are on for bipolar disorder have sedating effects. And so it could be as simple as talking to your provider about maybe I should be taking this right before bed instead of in the morning. Or should I take a higher dose before bed and a lower dose in the morning? So if sleep is really a struggle for you, again, talk to your provider, because there are ways that the medications you're already on could potentially be enhanced to improve outcomes related to sleep.
Yeah, I totally agree with what Sarah said. I mean, the cognitive behavioral therapy, it's more effective than medications, really. So that's the and it has less side effects too. So that would be number one. Um, and melatonin, you can get that over the counter, but it is important to use that in a specific way. So I really would talk with your provider about that. There's some other medications that you can use. But it's best to integrate that with the specific mood stabilizers you're on. So I wouldn't try to cobble that together yourself with Benadryl or anything. I would go with your provider on that.
Great. And there are several questions about adolescence and age of onset of both conditions, and some about whether, for example, use of a drug or marijuana during adolescence could make you more likely to develop the other condition later in life. Can you guys talk just a little bit about typical ages of onset and what unique questions you might be thinking of when we're talking about working with adolescents or young adults?
So for me, when I'm doing the clinical diagnostic interviews, a lot of times what individuals are reporting to me is that they're meeting criteria or starting to see symptoms of depression develop during the younger years. Again, we see that more along like early teenage years. They may have had their first depressive episode. Some of them were even hospitalized in high school for depression. Whereas when they get the official bipolar diagnosis and have a manic or hypomanic episode, that comes a bit later. And so we usually see that around their early 20s. Like I said, when they go to college, something they probably started to experiment with substances, so that may have onset it, but then even afterwards they get that formal diagnosis, they still continue to have manic or hypomanic episodes as well as depressive episodes, and that kind of lets us know that it just wasn't a one-time thing where the substance just caused that episode to occur, but it's ongoing and it continues to happen.
So substance use usually often starts in adolescence. It can also come in later in life too, with other life changes like retirement. Sometimes that can bring on a substance use problem. Um, I don't know of any links of a particular substance with causing bipolar disorder. Yeah, I don't think that's anything that people have found. It's pretty rare for bipolar disorder. It's not unheard of, but it can develop as a result of a head injury or something like that. But I don't know of any substances that can cause it.
So the one study that I am aware of that has really explicitly made a link between a particular substance and risk is for those who are at genetic risk for bipolar disorder, or which means they have a first-degree relative with bipolar disorder or a first-degree relative with a psychotic disorder. Early onset of cannabis use is a predictor of the development of primarily bipolar 1 disorder with psychotic features. So there's something really key to the psychosis there. And in general, the findings are more broad, that earlier age of onset of use, and that's not abuse, but just earlier engagement in experimentation with illicit substances is associated with higher risk. And again, that doesn't mean it's causing it, right? I think the days are gone in us thinking there's just one cause of something. And so we really recognize that it's a combination of genetic and biological factors, environmental factors. And I really think, and Erica highlighted this, I think about substance use as a stressor, right? So if I'm a system that's vulnerable, maybe I've had some depression, maybe I have a brain that's reward hypersensitive, and I start using drugs or using them more heavily or with more intensity, that could be the stressor that just kind of sets my system on fire, for a lack of better words. So we call that a diathesis stressor. It's that the substance use is making you more vulnerable to then have what's already kind of underlying come out. And so if you weren't using substances, it's possible that even if you have a system that's at risk, you might be more resilient and able to not develop a full-blown bipolar 1 disorder or something like that. So I really view it as a stressor, a physiological and psychological stressor on the system that makes you more vulnerable to have many different forms of psychopathology, not just bipolar disorder.
Thank you. And I think that's a really a good way to think about this topic area, and maybe a good place for us to end. I'm realizing we're closing in on 8:30, and we should probably wrap up. I hope that all of you in the audience found this information be helpful. We provide a couple links in the chat, including our department's resource pages for both the addiction clinic as well as the clinic for treating bipolar disorder. A recording of this webinar will be available and emailed to everyone as soon as it's available. And we really appreciate the active dialogue with us in the Q&A. And hopefully we got through many of those questions, but I think there are still about a third that we didn't get a chance to respond to. So please feel free to reach out to us if you have any remaining questions. This educational series and other educational events are made possible through the generous donations to our department. If you're interested in making a gift to support U of M's research and their training programs, which address the needs of people with substance use disorders and bipolar disorders, we'd welcome your partnership. We'll put contact information in the chat, and you can also always visit our website. Thank you to Sarah, Jonathan, and Erica for their presentations, and thank you everyone for attending. Take care.